Alright, so let's talk about class 3. We need to evaluate these because they're potassium channel blockers. These are amiodarone, ibutylide, dofritilide, and sotalol. All of these drugs are particularly effective at prolonging the repolarization phase of 3 because they bind the potassium channels that drive the potassium efflux that is responsible for this repolarization phase. So this makes sense that we could extend our overall action potential because it takes longer for us to repolarize. As you can see in the diagram, the delayed opening of the repolarization potassium channels will significantly prolong your QT interval because your QT interval includes the ventricular repolarization phase. Any drug that prolongs your QT interval can set you up for that deadly French arrhythmia, torsades. So due to the risk of prolonging your effective refractory period and your QT interval and predisposing yourself to torsades, you only use this class of antiarrhythmics as a last reserve. There's no way they're going to ask you a question about actually using this drug on somebody. But they will ask you a question about someone that was previously on this medication and had been continuing to take it and then develops the side effects. The side effects here are your money maker. That is the way that they're going to approach this class 3 antiarrhythmics because they're so dangerous. You must remember how not to kill people. Amiodarone is a drug like digoxin. So many side effects and mechanism of action that you can guarantee question writers were not only tested on it when they were going through med school, but they are going to try to incorporate it somewhere on your exam as payback. You absolutely must know the side effects because you can be presented with a patient that has signs and symptoms of some sort of organ system malfunction due to the effect of one of these drugs, particularly amiodarone. So let's go ahead and talk a little bit about this amiodarone. It absolutely loves lipids. It is very lipophilic and it is metabolized very slowly in the liver. And then it is excreted into the skin, into the bile, and the lacrimal glands. Just knowing the metabolism and how it's excreted can help you remember that it can lead to hepatotoxicity from causing damage to hepatocytes. It can cause corneal and skin deposits because of the excretion via the eye and the lacrimal glands and then the skin. Amiodarone can trigger a hypersensitivity-like reaction, which is what mediates its toxic effects on the lung and the skin. Usually, the hypersensitivity-like reaction will present as pulmonary fibrosis and photodermatitis. The antibodies produced against amiodarone will deposit in the pulmonary vasculature and cause a fibrotic response, and they can also deposit in the skin capillaries and cause a fibrotic response after the damage has been done. So what about the thyroid gland? So if you just look at a part of amiodarone, it's a very large molecule, and I'm not going to draw it out for you, but the central ring, all you need to remember is this right here. So it's got this ring, which makes it very lipophilic because it is a particularly nonpolar structure because it has a bunch of these phenyl rings. But more importantly, it's got these iodines on it. Guess which organ needs to take up iodine to function and will essentially get tricked into binding some of this amiodarone? Your poor thyroid, poor guy. Amiodarone can alter the conductivity of cells. Why? Because it's so lipophilic, it can sneak through any barrier, particularly the blood-brain barrier, and go damage neurons in the brain and also in the periphery. It can go after pacemaker cells of the heart, and this gives you signs of the neuropathy or paresthesias, weakness, constipation, and then bradycardia. Amiodarone is a very unique drug in that it can block every type of channel that we've discussed. It can block sodium channels, it can block potassium channels, and it can block calcium channels. And this can cause actually a decrease in conductivity of the AV node and a significant bradycardia. So there's two ways that we can get bradycardia: direct damage to the cardiomyocytes and then also decreased conductance to the AV node. By blocking potassium channels, it can also lead to some of the deficits in neuronal conduction. So there's another way we can get manifestations within the neurons. And then by blocking the sodium channels, we can also alter neuronal conductivity and cardiomyocyte conductance. So there's mechanism of action can be potentially related to some of these side effects, and then some of the damage that can be done by direct amiodarone-related toxicity means that you must know this drug because it is incredibly dangerous. It is very complex, multiple mechanisms of action, multiple side effects that will kill somebody. So because of the ability of amiodarone to cause the pulmonary fibrosis, liver damage, and thyroid damage, you always need to check pulmonary function tests, liver function tests, and thyroid function tests. And these are often abbreviated PFTs, LFTs, and TFTs. Okay, great. Before we discuss verapamil and diltiazem, it's important to remember that the SA and the AV node are the two places in the heart with particularly high numbers of calcium channels. Remember, calcium channels are also important in the vasoconstriction that occurs with vascular smooth muscle cells. Verapamil and diltiazem are non-dihydropyridine calcium channel blockers. All that tells you is that they're not dihydropyridines, which kind of tells us that they don't really favor vascular smooth muscle cells as much as the dihydropyridines, because we know dihydropyridines are notorious for blocking calcium channels in vascular smooth muscle cells. All the dihydropyridines in DIPINE, such as amlodipine and nifedipine, and that tells you which class we're talking about. The class that the calcium channel blocker belongs to determines how selective it's going to be for the myocardium or vascular smooth muscle cell calcium channels. Verapamil is a phenylalkylamine. That's not important for you to know, but it tells you that it's in a completely different class on its own, which makes sense because it has the highest selectivity for the myocardium. While the benzothiazepine class, which includes diltiazem, hence they both have ZEM, has an intermediate selectivity for both cardiac and vascular smooth muscle channel receptors. So again, verapamil, think about mainly affinity for the heart, calcium channels, and then diltiazem with a almost equal selectivity for the heart and vascular smooth muscle cell channels, but slightly greater for the heart. Now, why is this important to you? Well, we know the dihydropyridine class is completely selective, almost, for the smooth muscle cells. So let's talk about verapamil. It is largely selective for the myocardial calcium channels with very minimal influence on the vasculature smooth muscle cells. So what does that do? It will sufficiently decrease the phase 4 of the pacemaker potential because it blocks the influx of calcium. Remember, the phase 4 depolarization is responsible, Remember, the phase 4 depolarization is mediated by the calcium influx that is triggered by the slow depolarization through the funny channels. The funny channels conduct sodium, and that causes an increase in the transmembrane potential towards a more positive value, and that eventually triggers those calcium channels. So by giving verapamil, we decrease the slope of phase 4 because there's less calcium influx, therefore less velocity of the upstroke. As you can see, the rise of the action potential is dragged out. It is more slanted as opposed to this. It takes a much longer time to reach that same peak. So by decreasing the slope of phase 4, you can see that the rise of the action potential is dragged out. We will not initiate impulses at the normal rate. This will increase the PR interval because the PR interval represents the period in which the impulse is delayed through the AV node. And because we're blocking calcium channels, particularly in places that are heavily dependent on calcium conductance, such as the SA and AV node, it makes a lot of sense that we're going to decrease the activity of calcium channel opening in both of these locations. And also, by causing a mild effect in the vascular smooth muscle cells, you get some vasodilation. The effective refractory period will also be prolonged because verapamil and diltiazem prefer to bind calcium channels on the inside of the actual calcium channel. This means that they will preferentially target places that are in the conformation of either recently depolarized or returned to the active state. So here we have a calcium channel where this is the extracellular and this is the intracellular. This is allowing actual calcium to flow in, and this is not allowing calcium to flow in, but the calcium channel blocker needs to access the inside of this channel to bind and have its inhibitory effect, which means that it takes longer for these channels to return to the active state, which is when the activation gate, which is the straight line, and the inactivation gate returns from the closed position back to the open. So again, let's just quickly review that. This is our calcium channel. This is the intracellular environment. This is the extracellular environment. After depolarization, you have to open this activation gate while the inactivation gate remains open. This is an opportunity for the calcium channel blocker to block the calcium channel. Also in this state, we still have the activation gate open, but we've slammed shut the inactivation gate. Even though there's no conductance of calcium, there's still an opportunity for the calcium channel blocker to block the channel and return to the ready to fire state. This means that they will preferentially target areas of the heart that are being depolarized a lot because they have more opportunities to access channels that are in this conformation or in this conformation. And that is why they are of particularly important clinical use for supraventricular, so above the ventricles, tachycardias, and atrial fibrillation, which is basically a type of supraventricular tachycardia, and is also very helpful for AV nodal arrhythmias, in which there is an abnormal conductance through the AV node, because it will decrease the conductivity of those calcium channels and allow you to stabilize the conducting rate through the AV node. We need to be careful though, because if we decrease calcium conductance in the pacemaker cells excessively, we could actually end up causing sinus node depression. So, SA node depression, AV node depression, or block. And excessive block of either one of these will actually lead to acute congestive heart failure because the heart will not be able to pump because there's no calcium conductance telling the ventricular myocytes and atrial myocytes to conduct. The ability of these drugs to inhibit the calcium channels that are largely responsible for the conductivity in the SA and the AV node means that these drugs are dangerous when we exceed the therapeutic window. But if used at an appropriate dose, these drugs are particularly helpful for preventing supraventricular tachycardias because you do not want that supraventricular heart rate to transmit down into the ventricles. The same thing goes to atrial fibrillation. In both situations, the atria are stimulated way too fast and need to be slowed down. And you also want to prevent the AV node from responding to these depolarizations. So decrease the conductance of the AV node with your calcium channel blocker so that the super fast heart rate in the atria does not transmit to the ventricles because the AV node will be refractory because we're inhibiting its calcium channels. This will ensure that you have sufficient time for your ventricles to fill in diastole. Now what about the effects of constipation, flushing, and edema? You think I was just going to make you memorize these? No, I wouldn't do that to you guys. This is step one time. This is very serious. We've got to know the mechanism of action of not only the drug positive effects, but the negative effects. You probably already know the mechanism behind these side effects if you have mastered all of the information we covered in the physiology section, which I'm confident you have. Remember, we're blocking calcium channels, not only in the myocardium, but also in vascular smooth muscle cells. Where are vascular smooth muscle cells located? Everywhere. So, not only can we block calcium channels in vascular smooth muscle cells, but we start blocking them in other locations, including the interstitial cells of Cajal. The interstitial cells of Cajal are responsible for the slow wave potentials that cause the intrinsic peristaltic movements of the stomach, duodenum, ileum, and colon. If you block these calcium channels within these cells, you get a hypomodal environment. They're going to be constipated. You better believe that your patient is going to feel constipated because their gut intestinal smooth muscle is just not contracting as much as you need to have normal bowel movement. The flushing and edema are related to changes of the diameter of arterioles in the papillary dermis. Now, papillary means finger, and then so you have these projections, and this is the skin surface. So if we incredibly dilate this vessel, it'll be much closer to the skin surface, and that will cause a redness because you have increased blood flow to this area and the proximity to the surface of the skin is closer. The edema is also related to increase in hydrostatic pressure because of increased delivery of blood to the area. You can actually cause some transcapillary leak, which means that fluid will go across the capillary wall and collect in the interstitium, and this gives you edema.